welcome to Medical Dialogues. I am Dr. Nandita Mohan, and today I will be taking you all to explore the world of rare diseases. And my topic for today is Weil Syndrome. Now, to help us understand this in a little bit more detail, we have with us today two experts, Dr. Pramod Kumar DA, who's a consultant hepatology and liver transplant physician at Glen Eagles Hospital with over 13 years of experience. And we also have Dr. Subramanian Swaminathan, Director, Specialty of Infectious Diseases at Glen Eagles Hospital with over 25 years of experience. So I welcome you both to Medical Dialogue, sir. It's really a privilege to be having you on board here with us today.
Pleasure.
Now, thank you so much. Now we're talking about Weil Syndrome. To Dr. Pramod, if I may start with you first. So what is Weil Syndrome? If you can just briefly explain to our viewers, and how does this specifically affect the liver function, and what are the most common complications that you usually encounter?
Weil syndrome is nothing but it's a severe form of leptospirosis, characterized by again the onset of jaundice. These patients can develop kidney failure along with bleeding manifestations. It usually occurs in less than 10% of the patients, again associated with very high mortality, ranging between 15 to 40%. If you come back to the liver involvement, again it ranges between asymptomatic rise in transaminases to fulminant hepatic failure in very rare cases. And the most common complications we come across is again the severe form. Usually these patients require critical care admission, again the presence of jaundice, and most of these patients have acute renal failure along with encephalopathy.
Okay, great. Now, to Dr. Subramaniam, if I may ask, what is the current understanding of the transmission dynamics of Leptospira bacteria? As Dr. Pramod mentioned, that is the common cause that causes Weil syndrome.
Leptospira should be actually viewed as a zoonosis. It's something which is endemic in rodents, especially rats. And humans are a unfortunate victim of this. So as human population rises, rodent population also rises. And unfortunately, when we think of rodents, we always think of plague. But there are lots of other infections which can also be transmitted by rodent infestation. And this is usually transmitted through rodent urine. So when somebody steps on rodent urine, they may or may not be aware of that. Even through minute cracks in the skin, the organism can get through. And once it's in, it has lots of frequent flyer miles to burn and it gets everywhere. Unfortunately, what we should remember is that rodents have a tendency to pee when they are scared or when they are under stress. And when there is incessant rains and flooding, there's a lot of rodent urine contamination in the flooded waters. That's why we generally see more of these things happening during the rainy season, especially when there is incredible flooding and things like that. So obviously there is a seasonality to it, and there is obviously related to rodent infestation. So if you don't have rodent infestation, awesome. Unfortunately, that is not necessarily a fact of life for most of us. So we have to be careful about this.
Most of the times it is rodent or any other animal.
Well, other than rodents, again, we don't have very good data on other animals transmitting it. It's possible, but obviously the greatest concern for us are the rodents. Absolutely. Oh, don't go for farming community. Even in urban centers, we have no idea how many rats there are. I mean, you don't even want to know.
It's not documented anywhere, so I know definitely the numbers are not out. So I think people are not aware about how infectious this can actually become. This disease can actually turn into. Now coming back to you,
I'm sorry, I'm going to interrupt you and tell you this. See, if there are no rats in the urban centers, why are we seeing Leptospira? If you're seeing Leptospira, it stands to reason that there are rats. It's just that we don't see them, or we don't want to see them.
Actually, very well stated. Actually, so be it urban or rural population, rodent population is a match to the human population.
Absolutely. Absolutely.
So yeah, talking about this in a little bit more detail, coming back to you, Dr. Pramod. So if you can just discuss the challenges in distinguishing Weil syndrome from other liver diseases with overlapping symptoms.
Again, most of the times the most common cause of jaundice again is viral hepatitis. Again in southern part of India, we commonly see hepatitis A, acute hepatitis A. followed by many times hepatitis E, followed by acute hepatitis B, or many a times again the tropical infections, commonly again malaria, dengue, leptospira, even the scrub typhus, also the typhoid. These are the common syndromes, tropical syndromes can mimic the acute hepatitis kind of situation. Again, if you look at the differentiating factors, most of the patients with acute viral hepatitis, because of hepatitis A and all, they present with initially prodrome fever and followed by the onset of jaundice. Whereas in patients with tropical syndromes, usually they have fever, ongoing fever, along with they develop jaundice as a part of multi-organ system involvement. And if you look at the other manifestations, they do have renal involvement or low platelet count or hemorrhagic manifestation kind of thing, which is again very uncommon in patients with acute viral hepatitis.
Okay. Now, Dr. Subramaniam, coming to you again, how would you differentiate Weil syndrome from other infectious diseases? Now, we want to know it from the expert himself. So, infectious diseases like I'm talking about dengue or malaria, or any which have such similar presentations.
That's not necessarily a very easy thing to do. We have rules of thumb, but then again, every rule which has an exception, this one also has exception. So let's be very honest about it. So the first thing is, like he said, this usually presents with high-grade fever, and the patients start developing liver symptoms within the first 1 week itself. By day 4, day 5, they will have significant jaundice and liver enzyme injury. And if you look very carefully, many of them have eye hemorrhages also. So, that's why we call it Leptospira icterohemorrhagiae, lovely name. So, if you find conjunctival hemorrhages, that is a very interesting thing. Although it's not either classical or it's not sensitive or specific to this, but yes. Low platelets obviously is an important manifestation, but keep in mind there are other infections which can cause low platelets. So general rule of thumb is by day 5, if you do not have a low platelet, you can exclude falciparum malaria, scrub typhus, leptospira, and dengue. So these 4 can be excluded. So basically, you only have these 4 as your differentials if you have fever with low platelets by day 4, day 5. And if you add jaundice to it, significant jaundice to the point that you can see yellowing of the eyes, icterus, scrub generally doesn't do that much of liver injury to cause jaundice per se. Malaria usually can be easily figured out because we have high-grade fevers and rigors, and the peripheral smear is very good. Today we have rapid tests which you can use to identify falciparum malaria. Not Vivax. Vivax doesn't cause thrombocytopenia. Falciparum does. So, and today falciparum malaria has become much less of a problem across India as it was, say, 30 years ago. And dengue, of course, we have good tests. And by day 5, the fever is already coming down. In Leptospira, day 5 is just when it's getting started and you're getting a real wallop on the backside. And if you wait longer than this, which I would not advise, the patient starts developing renal injury. Now, what happens is, because everybody is so aware of scrub typhus and almost every fever is being treated as a doxycycline deficiency syndrome, Leptospira also gets covered for free. I'm not suggesting that everybody throw doxycycline at anybody who has fever. I'm not suggesting that at all. I'm just saying that if you're worried about scrub typhus and you think clinically you're thinking of scrub typhus and you're using doxycycline, you're also covering Leptospira for free, so you don't have to separately think about it. But keep in mind that the manifestations can sometimes be overlapping, so you cannot differentiate one from the other 100% of the time. Sensitive tests like PCRs and things like that are not easily available. The problem is we are still using drug tests like the MAT, antigen agglutination tests and all that. They are not really that great. They are decent. They're far from perfect. So I go more by the clinical symptomatology and the overall profile, and keep in mind the time of it. If you have it in the rainy season, the probability of being leptospira is very high. On the other hand, the whole place is bone dry and there's not even water to drink. You're probably not thinking leptospira.
True. Now, coming to the treatment aspect of it, we discussed what the symptoms patients usually show for Weil syndrome. So, Dr. Pramod, how do you approach the treatment strategies for liver damage in Weil syndrome patients, particularly if we're talking about severe cases?
Most important thing again, the treatment of primary infection with the antibiotics. Whereas the liver injury, again, the severity ranges from asymptomatic to the severe. The bilirubin can go up to 60, 70 milligram per deciliter in some cases. Again, depends on the severity of liver injury. If the liver injury is very severe, again characterized by the coagulopathy and along with the involvement of hepatic encephalopathy, then these patients may require the liver supportive treatment, kind of like NSTL cysteine infusions. And along with this, in these patients, severe patients, we can also try plasmapheresis, and also along with the continuous venous infiltration, the hemodialysis kind of thing. Again, in order to support the liver, so that the liver can regenerate in the meantime. And some patients even end up getting liver transplantation rarely, again, if the liver don't recover with all these secondary medications and supportive devices. And most of the times, these patients have other organ involvement. That is the most important. Again, the encephalopathy could be due to, again, the meningoencephalitis kind of thing because of leptospira infection. Differentiating, again, it is related to the liver failure or primary CNS infection is the foremost important. Again, the treatment depends on the severity.
Okay, understood, understood. Now, coming to you, Dr. Subramaniam, we're talking about the treatment strategies. What advancements, coming back a bit from the treatment aspect to the diagnosis aspect of it, so what advancements have been made in the early diagnosis to Weil syndrome and basically to improve patient outcomes?
Advancements will only be made when the problem is for the white man. Advancements are usually not made when it's a problem for the brown man or the black man. I'm sorry to be very blunt about it, but we must be honest about it. So yes, there is a lot of research happening in terms of availability of PCRs and tests like that. But unfortunately, there are lots of issues in this. Number one, if it's an in-house brew, you need to figure out how exactly the performance characteristics are. Number two, you need to have a demand for these tests. Most people are not even asking for tests, and they're still hung up on old tests like MAT. The first thing is that, of course, our clinicians may or may not be aware that leptospira is an issue. And because they're using doxycycline for everybody and a beta-lactam for every fever, you are going to cover leptospira anyway, and it's going to get better. So you may not even know you're having leptospira. And if you don't know what you're handling, you're not going to test for it. So there's a lot of lack of knowledge and a lack of awareness of leptospira. Second is, the clinicians don't realize that the tests that we have are actually not that great, and your test, unless you ask for it, it's not going to happen. So it's all fine and dandy setting up PCR. If nobody's going to send samples for it, they're going to wind it up and say, the administration is going to say, you're giving me an unmarketable test. What is wrong with you? And that's not something anybody wants to hear. So I think we need to have more demand from the community before we start talking about scientific advancements to make diagnosis better. Remember, it's always that the solution rises up to meet the challenge. You cannot create a solution in vacuum and hope that the challenge will come up to fit it. So I think it is very important for us to start asking these questions so that more of these tests will become commercially available. You talk to many of the commercial labs, they'll tell you, sir, we are only doing basic tests for this, we're not doing anything more than that. So I think it's important for us to start asking for this. I think that's the most biggest innovation we need to do.
Very well, very well. Now, lastly, if I may ask both of you, how can interdisciplinary collaboration between hepatologists and infectious disease specialists like yourself, Dr. Subramaniam, improve the care of patients with Weil syndrome? So how can this collaboration actually work, and how interdisciplinary approach can help in early diagnosis, and then we proceed towards prompt treatment?
See, this discussion is an example of that. The point is that we have to accept that there are limitations to our knowledge. There are things we need help with. Nobody knows everything, right? Subspecialization is a process by which we know more and more about less and less until we know everything about nothing. And therefore, we are even more reliant on others for help. And we need to be humble enough to say, you know what, I could do with some more help. So why only hematology and hepatology and infectious disease? Bring in primary care, bring in intensive care, bring in neurology, bring in nephrology. I think there are lots of stakeholders who can be part of this. Pediatrics could be part of this. Oh, hell, even OBGYN could be part of this because you don't know what happens. So I think there is a scope for a lot of different people collaborating on this, and not just for care, but also for data collection and understanding syndromes. Because we are still stuck in the 2000s in terms of Leptospira, because we're still discussing the same thing we did about 20 years ago in terms of this. How the disease behaves, this is what we do. See, fortunately, we are lucky in that Leptospira, being a spirochete, does not develop drug resistance very quickly. Benzyl penicillin still works for it. Doxycycline still works for it. And like every other spirochete, like syphilis, it has CNS penetration, which is fairly quick and all that stuff. So it behaves like every other spirochete. It still hasn't changed its stripes and things like that. But that doesn't mean it is any less pathogenic. People often confuse this, isn't it? We think that if it's not very resistant, it probably is not a big deal. Necrotizing fasciitis is caused by streptococci, which is penicillin susceptible, but it's one of the most dangerous diseases known to humanity. So Weil's disease is also pretty scary if it's not identified on time. So I think what we need to focus on is making sure our clinicians are sensitized to this. It sometimes is difficult because everybody comes and says these are only 5 things you need to know. And at the end of the day, if you have 100 people saying only 5 things to know, that's 500 things. Nobody can remember that. So I think for us, we need to start remembering it in terms of pattern recognition and say, okay, you got strep typhus and you're thinking of dengue and you're thinking of falciparum, include vials in that. And that's the way I think we can do that. And then get more people involved. Get the hepatologist, get the hepatologist, get the nephrologist, whoever is necessary. Work with everybody because, if you don't get it, maybe they'll get it and help you, and ultimately the patient benefits.
Again, early identification is the key.
Absolutely, yeah.
Very true. So it has to be a multidisciplinary approach, and definitely early diagnosis. It will help in early diagnosis if there are multiple thoughts as well. So it's going to benefit the patient, as you correctly mentioned. So yes. So thank you so much, Dr. Pramod and Dr. Subramanian, for joining us today and giving us all your insights about Weil syndrome. And we just hope through this video we are able to send out awareness to more and more people to actually come down and catch the Leptospira bacteria at the earlier stage. So thank you so much once again for joining us today at Medical Dialogues.
Absolutely pleasure. Cheers.
Never miss a medical update from Medical Dialogues. Like, subscribe, and press the bell icon.